Yeah. Hi.
I doubled my excitement.
We are.
Well, good afternoon, everyone. My name is Gabby. I'm the Infectious Disease Program Manager. Today we have Jessica Leston presenting. She'll be giving her bio, but I just want to welcome you all back to the third session of Health Promotion and Disease Prevention. This is the final session for today. Make sure that you do the evaluations at the end. As you got settled, you will have that scan and be sent to you. And I will leave the floor to you, Jessica, which will be presenting on Syphilis outbreaks in American Indian and Alaska Native communities. And the floor is yours. Thank you.
Thank you. Thanks. Well, Amasani, Jessica Diwali. Hi, everyone. My name is Jessica. I live from Germany, Sweden, and Ireland. And my father's side of the family come to Turtle Island as settlers from Finland, Austria, and also Tsimshian from Southeast Alaska, originally from British Columbia in Canada. I have been working in tribal health for about 20 years now. I started off at the Native Tribal Health Consortium and started their sexually transmitted infections program back when even fewer people were talking about sexually transmitted infections. Now currently work at the Northwest Portland Area Indian Health Board and lead their Center for Clinical Support and Preventative Health Services program. I am probably just gonna stay sitting and talk to y'all. If you have questions, please go ahead and raise questions. I don't have a ton of, there aren't a lot of slides, so I wanted this to be sort of a generative conversation anyway. And introduce you to my love for my favorite sexually transmitted infection, which is syphilis. Truly it is. It's an interesting infection. It is a great imitator, and it's really increasing in prevalence in our communities right now. And so there's a lot to look for. And I guess also just since we're a small group and it gives us the luxury of getting to know each other a little bit more, do you mind just sharing who you are and where you're from?
Walk Willis, I'm a physician and Chief Medical Officer with USET. I mean, from Nassau, we were some information from the CMO, and I think it was this part of the world.
Oh, the Dear Travel letter that just came out around syphilis.
A month ago, really got my attention, so I was glad to see you.
Great.
My name is Asha Montes. I'm the LPN. I'm the Health and Wellness Coordinator on the Indian Tribe Community. I am Diana Rock. I'm one of the LPNs up in the office out in the territories up in New York. I do monthly provides care and
maybe syphilis.
yes, yeah, yeah, especially for here. Especially at several tertiary.
Oh.
But I keep reminding my mom it's an increase in nursing homes. So.
Yeah, a lot of people who were never diagnosed when they first got syphilis, yeah, or just in nursing homes now as well. Taylor, we're just doing introductions.
Oh, yes, hi, I'm Taylor Anderson. I'm from Cat Company. We are a public health marketing agency. I'm a creative director. Jess is a client.
Jacqueline Carter at USET, Chronic Disease Program Manager. Hi, I'm Anawa Miller. I am a citizen of
why am I drawing a blank? John Indian Tribe in Winter Haven, California, and I'm USET's THBS director. Thank you all for coming.
I'm Anna Garrett, also with USET, senior epidemiologist.
And we know Gabby from the introduction. So to folks who just came in, I said, if you have questions as we're going through this, let's go ahead and just have a conversation. I have, I think, like maybe 40 slides. So it won't take too, I do talk a lot, but it probably won't take that long to get through everything. So just the context of the syphilis outbreaks happening right now in Indian country. I really wanted to put this into the context of the Indigenous HIV/AIDS Syndemic strategy that was just finished up, version 1 of it, by the Indian Health Services, the Northwest Portland Area Indian Health Board, Cardia from Seattle, and then also representatives from all of the areas. So Vicki Bradley was the representative from the USET area that helped inform the strategy. And what the strategy did really was take all of the national strategies that, to be honest with you, I haven't read front to back. The HIV/AIDS strategy, the STI strategy, the hepatitis strategy, and pulled them all into this comprehensive strategy because of all, that's what we all are forced to do in Indian country anyway. Like we all do everything that we can because like we're the only people out there doing the work. Just in the way that this overlaps with substance use disorder and behavioral health and social determinants of health, housing, mental health, so much. So even though I'm talking about syphilis, it's only because it's my favorite. But like all of this is just like seeing it through an Indigenous lens, and it's all connected. Every single health issue that we have is connected. So, you know, what are we doing when we're treating syphilis, but we're not also addressing the reason why syphilis transmitted for this person, and maybe it's that they were injecting drugs, or maybe it's that they don't have access to condoms, or any of the other issues. This strategy is available. This QR code actually takes you to the strategy, and I know that that a lot of the work done in Indian country now around all of these things are going to be trying to incorporate a little bit more of the syndemic strategy. And then in the strategy, we have all of these different priority areas. We have sovereignty and how sovereignty can influence how we have policy and programming around the syndemic issues. For instance, tribe being able to draw up their own response using cultural responsiveness as a protective health measure. Cultural responsiveness being its own main message are the materials linguistically and culturally adapted to the community that they're going to be used in. Partnerships, developing partnerships not only between tribes themselves to learn from each other, also through local county health departments, through states and federal partners and academic institutions. Addressing awareness and stigma, because still it's very hard to talk about sexual health. It's really hard to talk about substance use disorder. I was just in a community two weeks ago, and the person who's doing harm reduction there was like tearing up because the work that she's doing isn't funded by the tribe, and she isn't paid by the tribe, but she's doing all of this good work, but nobody wants to see the work that's being done. So addressing that stigma that's currently out there around everything, and really pushing to see person first. It's not a drug user, it's a person who's using drugs right now. Clinical resources and services, so making sure everybody knows best practices everybody knows treatment strategies, and that there are health education avenues to be communicating all of that. And then lastly, data systems. Does your tribe have the most recent, most regional data that you can have on HIV, on hepatitis, on sexually transmitted infections? How can a tribe or a clinic more accurately collect their own data so that their infection control nurse or their STI champion can be actively monitoring what is being screened for and what the positivity of those tests are. So this is everything that the Syndemic captures. And when I'm saying Syndemic, it's funny, as I was putting together this presentation, I think last year, that I was talking about Syndemic too, in a different context. We were really focusing on the indigenous strategy then. But the current Syndemic that we're focusing on in this presentation really does deal with the rise of STIs. And I have been saying, and this is still true, I have been saying that, you know, the increase in STIs is predictable. COVID happened. So no one was coming to clinic. No one was getting screened. And those who were getting screened, no one was actively following up with them in any real sort of way to ensure proper treatment and to elicit their partners so that their partners could also get treated. Because rightly so, everyone was focused on COVID. And so in those years, the rates of STIs, including syphilis, really shot up, like very highly. And then also on top of that, like there has been defunding of sexual health in the United States for like the last 20 years. It keeps decreasing and decreasing, but people are still having sex, and there's more people having sex. And so there's this, you know, there's this inverse thing happening where if we don't start implementing new measures, there's really no way in a lot of communities that we're going to be able to change the outbreak situation of syphilis. And what that means is that syphilis is just going to be around, like chlamydia is just around, and like gonorrhea is just around, which makes it easier for HIV also to be around. In this endemic, there is a very clear association with substance use, with methamphetamine use, and methamphetamine use, and opioid use. Very clear association with people being houseless, not having phones, which makes it even harder to follow up with that person if they're not treated right then and there, if they need the second and third treatment, and then also to follow up with them to get their partners. And then there also are priority populations that are occurring with these outbreaks. In the LGBTQ population, mostly with men who have sex with men or gay men or bisexual men, but also, you know, with pregnant people, and that means heterosexual women as well, in adolescence, and then in racial and minority populations. And you'll see from some data a little bit later on, American Indian, Alaska Native people being the most disparately affected by the current outbreaks. And I'm using outbreaks loosely. CDC has labeled this an outbreak, but when you have like 1,000+% increase in syphilis in some areas, I'm just going to use it being an outbreak. There's also high morbidity. There's just a lot of syphilis going on in many places, and congenital syphilis is really increasing as well, and that means that babies are dying from a 100% preventable infection that just requires like one shot. So this increase in STIs, how it's endemic is that it also increases the chance of getting HIV. You know, STIs increase the chance of acquiring and transmitting HIV to others. And 6% of sexually acquired HIV infections are linked and attributed to chlamydia, gonorrhea, or syphilis infections. So just another way to ensure that we don't get more HIV cases is to treat sexually transmitted infections as soon as possible. And it also costs a lot of money to be maintaining such a high degree of response for all of these things. Yeah.
Do you mind if I ask a question?
No. Before you came in, you were late.
Yes.
Before you please interrupt me.
Tell him, Justin.
So do I not get to ask questions because I was late?
No, I'm just giving you a hard time because you're late, but I was joking. Yes, what's your question?
What does it mean exactly that they're attributed to chlamydia, gonorrhea, and syphilis? Is that just, it's a co-infection, or
It is, but
it's somehow caused?
I don't think you can do causation because it wasn't in a clinical trial,
Yeah.
but HIV is transmitted easier when there is an already growing infection. And so I think that that's what they were talking about.
Okay, that's what I thought.
Yeah.
Thanks.
Yep. And like I said, there's a really clear association with drug use here. In the current syphilis increase, young adults who used an illicit drug in the past year were three times more likely to get an STI. And this is specifically from CDC data, I think from like 2017 to 2021. It also, there's been an increase in sexual transmission of hepatitis. Always sexual transmission was listed as a route of transmission for hepatitis, but it wasn't a lot. It was not, and it's increasing in that being the route of transmission. So all of this stuff together, everything that I spoke about really calls for that syndemic response to the STI increase or the syphilis response, to the syphilis increase. We need this holistic and integrated approach so that we could provide person-centered care to people, meet people where they're at. And also just like not treat their syphilis and also not just treat their chlamydia, but really, dig at things a little bit deeper. If a young person comes in with chlamydia, they're having sex, right? Do they need any other kind of sexual health protection? Do they need condoms? Do they want to go on birth control? Do they need, what else do they need? So, and I think just to make everything that I said, like all of these data points, to bring it person-centered, there's this case from somebody who was in the Southwest, Tiffany. Tiffany was 17 years old, and she presented to the emergency department in late October of 2022, so just about a year ago, reporting a urinary tract infection. The symptoms of a urinary tract infection. Sorry about the UIT instead of UTI. So she was positive for the UTI. She also had a positive pregnancy test. So this facility was unique in a lot of places in Indian country in that it had an ultrasound that somebody could be working, and she was found to be about 14 weeks pregnant. So her UTI was treated, prenatal labs were drawn and sent, and she was referred to the prenatal clinic, which they also are very lucky to have at this facility. So they have an OB that is there. They have a gynecologist who's there at this facility. So the prenatal labs came back. She had an RPR of 1 to 128. I don't know. This is from Dr. Howe too. I don't know what happened. She had a TPP, she was TPPA positive, and she was positive for chlamydia. All of her other prenatal labs came back unremarkable. So multiple phone calls and public health nurse visits later, Tiffany finally presented back to clinic in early December 2022. So 2 months later, she comes in and is able to get treatment. She did have a rash at that point, which is great, because when she has a rash, that means that you can stage her very easily. She has secondary syphilis, and you can treat her with 1 shot of penicillin. But she's no longer with her partner, and she declines to provide his name, which is the big problem. So at that visit, she was treated with bicillin for secondary syphilis, and azithromycin for chlamydia. Her prenatal care and ultrasound was arranged. And the day of her treatment, her titer had returned at 1 to 64. So time goes by. In late January, after Tiffany had missed more prenatal visits, she finally returns for an ultrasound. And subsequently to that visit, where her labs were drawn again, her RPR was at 1 to 128, and she was positive for chlamydia. So they have to try to find her again, right? Because she's positive again. So in early March, after extensive outreach efforts, missed visits, the PHN, bless them, finally was able to find Tiffany at a site associated with meth use. And she had reunited with her partner, which is why she was positive for syphilis and chlamydia again, because Marcus was never treated. So that same day, Tiffany and Marcus both received field treatment of bicillin, and they were screened for everything. Follow-up prenatal care is arranged for Tiffany, and syphilis staging for Marcus. But again, despite extensive outreach efforts, Tiffany is next seen in early April in labor and delivery. She was 36 weeks. She had elevated blood pressure and apparent intoxication. She was positive in a urine drug screen for methamphetamine. She progressed rapidly during labor and delivered a baby with Abner 7 and 6. So the baby, upon delivery, their RPR was 1 to 16. Oh no, sorry, mom's RPR was 1 to 16. Baby's was 1 to 32. But the delivery had marked no obvious findings with congenital syphilis. However, baby had some respiratory issues and was transferred to an outside NICU. So after a full evaluation at the outside clinic, the baby was treated with penicillin for 10 days for possible congenital syphilis, but they were subsequently lost to follow-up, and the family reports that they left for sober living home in another state. These are so many of the congenital syphilis cases that are currently out there. They are almost 100%, I'm using that as not an epidemiologist, but it's so greatly associated with drug use, and not being able to come into clinic for treatment. And that is really why congenital syphilis is happening. These public health nurses did an amazing job. They found Tiffany 2 times, were able to treat her in the field with penicillin. So many places are still not even up to do that. And then the other side of this story is, what does this look like from Tiffany's point of view? Tiffany's an active substance use disorder, right? What does it take for her to get to the clinic for any of this treatment? How much does she struggle with herself being so addicted that she doesn't want to hurt the baby? This is from I had a conversation with somebody out in the Great Plains, and they were positive for syphilis. They had they don't want to hear about syphilis anymore, but that's okay. I'm going to keep talking about syphilis. This person was allergic to penicillin. She did not want to go into the clinic to be desensitized. because she knew that the clinic would draw her blood or urine and find intoxication with whatever she has. In this facility, she would have been placed in jail. So there's all of these things that are working together to make this outbreak situation, especially around congenital syphilis, really difficult. Yes.
Speaking into that, are you seeing across any of your partners where they're trying to combat that so they can have mothers come in without fear of being incarcerated and found positive for certain drugs? Because there's one of our clients was talking about they're trying to start that program. Is that something that like more people are trying to do?
I think I can only say like the tribes that we're working on with, there are the tribes that do have those laws we're working with to provide more education to tribal council to see about removing that code and putting in like actual health protections instead, harm reduction, increasing access to mental health, prioritize dependent people for mental health, access to treatment if they're addicted to opioids. So yes, I think a lot of places are looking into it, not all of them. So just for those who don't know, syphilis is caused by spirochete bacteria, Tropomina pallidum. It's really cute, spirally. I have a stuffed animal of it. It can be transmitted horizontally or sexually, and also vertically from mother to baby via the placenta during childbirth. It's totally curable with penicillin in every single stage, and there are 4 stages: primary, secondary, early, non-primary, non-secondary, and unknown or late duration. So the difference is that the early latent is within a year of first infection. And then late latent or of unknown duration means like you really do not know when the person acquires syphilis. And it's in that late latent period where you need 3 shots of penicillin instead of just 1. So it's really important to do everything possible really to catch syphilis as early as possible and try to stage it in primary, secondary, or early latent. It's especially with the bacillin shortage. There's a good chance that we will run out of bacillin by the time it's restocked. So we're really trying to get it early. And although it's not often thought of this way, but you can get early neurosyphilis or ocular or otic syphilis at any time during syphilis. It's not just in late latent syphilis. And this is just showing that in primary, secondary, early, non-primary, non-secondary, it's just treatment with 2.4 million units of intramuscular penicillin, and then of late, it's 3 doses, and then breaks out a little bit differently for the neuro, ocular, and otic, and then also it's differently for congenital syphilis as well. So what the data shows us is this. Sorry, and I'm talking about. So primary and secondary syphilis, these are rates of reported cases by county up until 2021, and that's the most recent data that we have. That's at least national from the CDC. And you can see what I see in this is that, yes, of course, you're going to have the dark blue or the highest rates in the larger city centers, but also the pockets of dark blue or darker blue that are elsewhere really do overlap with reservation or tribal lands in those rural spaces. This looks like from 2012 to 2021. So you see there's this, the map is just turning blue. You you know, this is the syphilis flu. And I bet you in 2022 data is just going to be darker. And more states are going to have more cases of syphilis. And this is what happened in the last year. From 2020 to 2021, American Indian and Alaska Native people surpassed Black African American people and have the highest rates of primary and secondary syphilis, followed by Black and African American, Native Hawaiian, Pacific Islanders. And you see that those races really are disproportionate to the other races in the United States. And I just captured this to show what congenital syphilis looks like by cases and rates of live births. And I start out those states in the top 15 that are in USET territory. I think I got all of them. So those are the states that have the higher rates. And I would imagine American Indian, Alaska Native people have higher rates there as well. This map is a little bit different from the one that I showed you. This one is looking at syphilis all stages, reported cases in women aged 15 to 44 by state. And you'll see this map changed drastically as well. It's even darker blue. So there's even more younger women that have syphilis. And this is really important because when younger women have syphilis, you're also going to have more congenital syphilis because they're the ones having babies. And we do see that. And what you see in American Indian and Alaska Native people is males have higher rates of syphilis because of association with men who have sex with men. But the female rate in American Indian and Alaska Native people is much higher than the female rate in any of the other races or ethnicities. This isn't because like there's something about American Indian and Alaska Native people. It's purely because of access. It's purely access to care and how they are receiving not only health care, but prenatal care as well. And you see that here in a different way. You see the female rate moving through the years up, and then also the congenital syphilis rate moving up in the years. Just a very clear association, and why wouldn't there be? And these are both the cases and the case rate of like when you're looking at all race and ethnicities in the United States. And people always, I hear often, but there's not a lot of American Indian Alaska Native congenital cases. And I always either like think to myself, or depending on where I am, reply back, yes, because like there's been a systematic extermination of American Indian and Alaska Native people, and there are only 5 million people left. So when you're looking at that 5 million, 102 cases is very high, and it's a case rate of almost 400 per 100,000 live births. It's a lot. And this just shows an even greater disparity of American Indian, Alaska Native congenital syphilis cases compared to everyone else. So there's clearly a problem. I've been talking about syphilis so much this past year. I think it's like almost the only thing that I'm talking about. And this is a huge problem that we have so many congenital syphilis, that we have such a high congenital syphilis case rate. There's no excuse for it. There is really no excuse for it. And the response needs to happen yesterday to what is happening with congenital syphilis in American Indian and Alaska Native people. And so much of that is tied to misprevention opportunities and really like good maternal child health care, good care to prenatal care. You'll see like the biggest things that are tied with congenital syphilis as a misprevention opportunity are that there's no timely prenatal care and no timely syphilis testing. And that there's no adequate maternal treatment despite receipt of timely syphilis diagnosis. So many times, because it happens in different silos, like a person will be diagnosed with syphilis, and they'll access the healthcare system. They'll go pick up meds. They'll go in for their dental exam. They'll go to primary care or the emergency department. And because, you know, there's no time to look back at charts, or because it's not properly documented, that person with syphilis who's pregnant is able to walk into the clinic and leave the clinic without treatment. So those are the biggest thing, the biggest misprevention opportunities concerning congenital syphilis. And just to reiterate, there's so many factors that are contributing to the rise in syphilis and congenital syphilis rates. Reproductive health and family planning, which I was just talking about, prenatal care. What does screening look like at a facility? Are there community screening events? How long does it take for someone to get treatment? What does drug use look like, and what is the response to people who use drugs, mental health services, housing? So much stuff is roped into syphilis. So I already talked about the national penicillin shortage. Does everybody know about this? So yeah, so there's a national penicillin shortage. Penicillin is the only recommended treatment for pregnant people infected or exposed to syphilis. So we're really trying to keep penicillin for pregnant people. And the other treatment is various regimens of doxycycline. So in June of 2023, and then in a Dear Tribal Leader letter in July of 2023, Dr. Christensen from the Indian Health Service made the following recommendations regarding the syphilis response. Those included annual syphilis testing from people age 13 to 64. So basically following the HIV screening recommendations. If sites are on our PMS, there is a developed screening reminder for this. If not, you know, hopefully you are working with a off-the-shelf EHR that is able to develop a reminder for you, or there's some other way that you're doing annual screens at your clinic. She recommended having a bundle, which most sites have already, so that if you're testing, you know, for chlamydia, this bundle is going to encourage you to test for both chlamydia, gonorrhea, also syphilis, also viral hepatitis, also HIV, and add on a pregnancy test for anyone, you know, who may be pregnant. She also talked about express STI testing. So the idea that a person can walk into clinic. This can look a variety of ways, but one of the ways is that you go to, you know, reception, you say, I'm here for whatever you decide to name it. Most places are just saying an STI test. Some people don't think STI test is stigmatizing, and so they're like the red button or something like that. They just call it something different. Then they are triaged with a nurse. They get their screenings, and then they're notified of their results. So you never see a provider. The only time, you know, you wouldn't fall into this pattern would be if you had symptoms, right? If you had any symptoms, then they would be routed for a provider visit that day, not letting them leave, like somehow getting them into clinic. She also called for enhanced screening rates by screening outside of the hospitals and clinics. And I personally think this is so important, especially with like going to places like encampments, going to trap houses, places where people are using drugs, and providing care in those spaces. people know where people hang out. Heck, in one community that I visited a couple times, it's like a block away from the actual clinic, you know? And so being able to go and rethinking about what access to healthcare is, you know? Just having a clinic in a space isn't necessarily access to healthcare for some people. And so rethinking about how we can provide access to every single person that we are to serve. Also doing the field treatment for syphilis. Yeah. Yeah.
When they talk about screening outside the hospital and clinics, you know, his age range was like either 13. That's 7th graders, 8th graders. So you know, we're sitting there thinking, okay, we need to try to go into the schools for this. I mean, that's like a whole different.
Okay.
Yeah. So you know, we're still in the discussion phases about this. So you have anything? You seen anybody try to do that? Or I mean,
there have been school screening events. So there are communities where, you know, school boards and the tribes are supportive of screening events at the school, or if the school has like a school health clinic that they would do screening in the school health clinic. I think it's great to promote screening for young people. You know, a lot of young people are having sex and you can use additional screening. But if this is a barrier at this moment, I would say do what you can do to increase screening, right? So for the most part, that screening reminder is people who are coming into clinic. So the 13 to 64, and they really want to increase that age. Dr. Irlu just went with the HIV screening recommendations. But I mean, there are people 79, 80 plus years old that are positive with syphilis. So this is just a general guideline to catch way more people with screening. As far as screening outside of the hospitals and clinics, I personally would focus on, you know, houseless people, those encampments, places where people congregate, detention centers. There's like 40% positivity in a detention center, like for all of this stuff. I would really focus in those spaces, and then community events. I know a lot of people are doing things at summer powwows and Sundance and stuff like that, rodeos. Yeah, and I will have I'll provide links to a lot of the stuff in the next slide. So there's like a whole guide for express STI testing. So that goes along with that is field treatment for syphilis, you know, ensuring that there are standing orders for public health nurses or nurses that are going out so that they can treat if they come up with like a rapid syphilis in the field, or if they are able to find somebody on their active list. Presumptive treatment of syphilis for people who are contacts or people who have symptoms. Don't let them leave, treat them then and there. The worst thing is that they get penicillin. And then create and build awareness. The Stop Syphilis campaign, that's just stopsyphilis.org or .com, has so many different things that you can download. Billboards, well, you can't download the billboards, but like you can download the billboard image, flyers, rack cards, postcards. You can order like flying banners or whatever those things, shark fin things, covers for your tables, condoms. There's a lot of stuff that you can order. Taylor helped up. Taylor did. Kat did a lot of that work. Taylor too. So I won't talk about each of these extensively. These are mainly, and you all have access to the slides as well. You can also just email me, Jessica.Leston@IHS is probably the easiest one. But this QR code goes to a syphilis crosswalk that was created. And it has links to so many different resources that like help along the syphilis pathway. Also, the use of rapid and point of care testing to test for syphilis. There are two different tests. There's the health check, and that tests for syphilis. And then there is also the ChemBio test, which is a dual test, HIV and syphilis. They're both 15 minutes-ish. And a lot of sites are using these in their emergency departments, because a lot of the times people come and people go, but you really want to know right then and there. They're using them at community events when they're going out and doing, you know, clinic outside of the four walls. So if anyone wants to get some of these to test them out in their clinic, just talk to me and I can send like 200 or, you know, whatever you can use to test them out to see if they work for your flow. Also, the use of incentives has been so successful. There was one place where a pregnant woman came in for another screening test because she knew that there was incentives and you could go like 3 months after your first one, and she came up positive. And the only reason why she came in to get screened, she wasn't accessing prenatal care. She was coming in for the incentive. So we are sending out $10 incentive gift cards to facilities for as long as that lasts, for as long as the funding lasts for this. But it has proven to be very effective. This is the stopsyphilis.org site, an example of the condoms that you can order, the cards, the billboards. Here they have two of the same billboard up there. I just wanted to know that I asked for that person to be holding up the peace sign. That wasn't part of the campaign. I just felt like it fit. But a lot of the syphilis stuff is geared around, you know, protecting yourself and protecting your community, right? The more syphilis that's screened, the more syphilis that's treated, the more your community doesn't have syphilis. So grandma's in there, grandpa's in there, auntie's in there, young people in there. Also, you can order an HIV test if you text native test to 55251, and that goes straight to it's a person, right? So you order it to test yourself at home. It's the at-home test. And then I Want the Kit will soon have chlamydia, gonorrhea, syphilis, HIV, hopefully hepatitis at some point. And that too is person-centered. So someone will go on, order these tests, it'll come to their house, they'll mail back the samples and get their results. This isn't turned on for anyone in like USET area yet, except for Maryland, because that's where it started at Johns Hopkins.
That answered my question then, because I was going to ask, I know Cody had spoken with me about how they were broadening that text native test. Do you know when they expect it?
If you want to push it, just reach out to Cody and we can start working. I mean, I think the biggest issue is working with you and with others to figure out what the priorities are statewide. Like I know that Eastern Band has already requested it, so I think that state, North Carolina, would be first. But then just where are other places that want it turned on?
Okay.
And we're just finishing up with the new marketing materials and everything for this. So even though it's turned on in like Great Plains, Southwest, Navajo, and all these other places, Oklahoma, it's not being like totally utilized yet. We haven't done the big push to really ensure that more people know that it's up there. The magic marketing. I don't know how it works. And then I've been talking a lot about people who use drugs, but for so many reasons, creating services for people who use drugs, including harm reduction. It's going to help with the syphilis outbreaks. It's going to help with hepatitis. It's going to help with HIV. It's just going to help the person, you know. Like there's data that are out there that people who have access to syringe service program are 5 times more likely to enter some kind of treatment. Doesn't mean they're going to stop, but they're 5 times more likely to enter treatment. And so the harm reduction centers are probably the best avenue for people with substance use disorder to be as healthy as possible and to consider treatment if that's what they want. It's not the goal of them. The goal of them is to meet them where they're at and to provide as much that you can as you can to keep raising. And then also really specifically services for pregnant people who use drugs. And that's in the plans of safe care. This QR code takes you to it. And this specifically is for healthcare providers and how they could integrate all of these services, including whatever the state reporting system is for people who are pregnant and using, including child protective services, including cultural care, including mental health, clinical care, all of this stuff. It's pretty comprehensive, it's very holistic. And we're coming out with some videos around this as well. I think this is one of my last slides. I'm really excited about this idea of street medicine. It's just this other way of providing access to care. It's being done in Northern Navajo, in Shiprock, and it's literally a clinician and a nurse that go out into the community, into spaces where people are using drugs. Not spaces, but gathering places. And they're providing rapid testing for syphilis and hepatitis and HIV. They'll do Vivitrol injections. They hand out Narcan and harm reduction kits and are starting to do Suboxone clinics there. They work with the local health center to keep pregnant people into some kind of care, even though the pregnant people aren't coming into the clinic. They'll find on average 2 to 6 new syphilis cases every week. And they also provide this communication with the jail system. And so if, for instance, someone was in corrections and they needed their 2nd or 3rd shot, they have that communication and they'll do that. Or if they need follow-up wound care, they'll do that. So it's really the people who run the street medicine program have the best relationship with people who are not accessing the clinic and getting healthcare that way. Express STI testing I talked about earlier. This is a toolkit that has like everything so that you don't have to recreate it. It has policy, protocol, examples of different kind of self-collection, treatment protocols, allergy protocols, all of this different stuff in this toolkit. There's also a pretty comprehensive presentation that was done on this that's recorded as well. And that's it. You feel free to email me or come chat with me if you want any of these stuff for your spaces. And I just hope maybe, your clinics start to do, like choose one of these things to do or choose all of them. But know that, you're not alone and that there's a whole team of folks at the national level and at USET that can kind of help guide you and build up essential healthcare at your facility.
Let's all give Jessica a round of applause. Thank you, Jessica, so much for your wealth of knowledge on such an important topic.